very well-known personality in the field of ophthalmology. Welcome Dr. Paul Rose to India here. And I think in view of having to rush out as well, I'll just make a long introduction short. Has done huge contributions, and one of which is really benefiting all our keratoconus patients. We do use a lot of Rosquet lenses here. I will, without much delay, hand it over to you, sir, to take us forward on your talk.
Thank you very much. Today, my address, if you just bring it up, thanks. Thank you for your attendance, and today my address is just going to be talking about scleral lenses versus corneal sclerals and why I see one has an advantage over the other. I am contracted as a consultant to Medicon, and I'm designer of the Rosquet family of lenses. Just to get our terminology correct here, corneal scleral lenses have shared bearing on the cornea and the sclera, where scleral lenses have all their bearing on the conjunctiva or the sclera. So there's quite a difference between the way the two lenses work on the eye. As you can see here, a corneal scleral lens actually has its landing zone inside the limbus, just inside the limbus, and then it vaults out outside the limbus to give you some standoff on the peripheral over the conjunctiva. So why the dramatic increase in the use of scleral lenses over the last 5 years? What has driven this change? The main reason is comfort. They are incredibly comfort. For those that fit sclerals or corneal sclerals will know, they're extremely stable and they give very stable vision. Not typically any better than a corneal lens, but they give very stable vision. They're also ideal for some dusty conditions, work conditions, and also for some sports where you want stability with the contact lens. But is there any possible downside? There is quite a bit of evidence coming out in papers. This one was in the GSLS in 2017, which analysed about 200 scleral lens wearers. And they found that 26.8% experienced midday fogging. I'll talk more about that in a moment. That limbal hyperemia was pleasant in over nearly 23.7%, and corneal staining in 13.3%. Can we ignore this? Also, Pat Caroline did a paper and showed that 25 to 30% suffer from conjunctival prolapse, and I'll show you that in a moment too. So let's look at some factors we consider. Firstly, lens settling time. There's several papers done on this. I'm going to quote this one done by the Mayo Clinic in America, where they looked at how quickly a lens settles on the cornea. They found approximately 50% of the settling happened within the first 2 hours, but it varied dramatically between different users of the scleral lens. Each one of these graphs here represents a patient, and you can see in some cases over 200 microns of change as the lens settles and the tears. In other cases, only 20. So how do you predict, if you're fitting a scleral lens, how much settling you're going to do? Are you going to leave it on the eyes 4 hours, 6 hours, 8 hours? How long is your fitting going to take? So they concluded the optimum time required for adequate lens settling has yet to be determined. So with a corneal scleral, usually within 20 minutes of insertion, because it only actually compresses the corneal epithelium by 20 to 30 microns. My design here, if we look at it, it was inserted here, 10:03. 30 minutes later, we still had the original 85 down to 84 microns, and 8 hours later, we still had that 85 microns of clearance. So you don't get the same settling with corneal sclerals as you get with sclerals. What about tear exchange? You don't usually talk about tear exchange with sclerals. If you look here, with a corneal scleral, you get some movement which enhances tear exchange. With a scleral, you get no movement, which makes a big difference to the amount of tear exchange you get. So this was a study done where they put fluorescent on the conjunctiva, and after several hours, 20 minutes and then 5 hours, they looked at how much fluorescence seeped underneath the back of the lens. So their conclusion was that after 5 hours of wear, roughly 1/3 of the subjects had absolutely no tear flow underneath the lens. And that was predominantly due to settling. Now we know that people wear scleral lenses a lot longer than 5 hours. So is it acceptable to have no tear exchange under a large percentage of these patients as they go through their wearing time? And you can see with the corneal scleral how easily tears exchange underneath the edge of the lens. The lens is designed to produce tear exchange. Scleral lenses aren't. So without tear exchange, I believe you're putting the cornea at more risk from trapped metabolites, discarded epithelial cells, pH and osmolarity changes under lens which must occur. This poses a higher risk of long-term problems with the cornea, such as microcysts and infections. What about diameter? If you land a lens completely on the conjunctiva, the landing zone needs to be bigger. Why? This is a perfectly fitting scleral lens. You can see we have a nice foot going out onto the conjunctiva. Try walking in shoes through snow and you'll sink in. If you wear snowshoes, which give you a larger bearing area, you don't. It's exactly the same with a scleral lens. Excuse me. So lenses that land entirely on the conjunctiva need a larger foot to stop them embedding into the conjunctiva. Corneal sclerals, you don't need to go as big. So why go bigger than you have to? Once you get outside 15 millimeters, the eye is just about always toric, and you have to consider toric options for your scleral lens. So if you can keep it smaller than 15 millimeters, it's easier to fit. You don't have to consider toric options as much. What about midday fogging? Midday fogging was found that 30% of scleral lens wearers have to remove the lens after 2 to 4 hours to replace the fluid in the back of the lens due to lipid content. Very infrequent with corneal sclerals. The reason why, you have a minimum tear layer thickness and the conjunctiva with the goblet cells is not trapped underneath the lens, so you don't get the expression from the cells trapped underneath. With, this is my lens again, XL, you have a 30 to 50 microns clearance only over the highest point of the cornea. The shallower the tear layer, the less likely you are to have midday fogging. And with most scleral lenses, they recommend at least a 200 micron volt. Corneal scleral, only 50. Conjunctivals prolapse, you can see pictures here. It's where the conjunctiva gets sucked back underneath the lens. Pat Caroline says this happens in about 1/3 eventually of scleral lens wearers. Is that satisfactory? Cannot occur with a corneal design, corneal scleral lens design, because the landing zone is inside the limbus. So you don't have the conjunctiva forced and sucked back underneath the lens. What about handling and removal? XL or corneal sclerals, very easy to remove. Simply put the sucker on the edge of the lens and it should come out very easily. Sclerals require a much greater force. They have much greater suction on the cornea and are much more difficult to remove than a corneal scleral. Finally, what about intraocular pressure? We don't think about intraocular pressure. Do you ever measure it if you fit scleral lenses? But this is one thing that's becoming quite an issue. A couple of papers. This one was done in February 2019, where they measured intraocular pressure and found that 19% of the patients wearing scleral lenses showed an increase of greater than 10 millimeters of mercury. One patient, in fact, showed a 15 millimeter increase in pressure. The average for all subjects was 5 millimeters. At the GSLS Congress this year, Pat Caroline did another study and came up with very similar results, with in fact one patient having an increase in ocular pressure of over 18 millimeters. Is that acceptable? For those that are wearing scleral lenses, do you check the intraocular pressure? Do you watch what's happening at the back of the eye? So what are the advantages, just to finish up now, what are the advantages of a corneal scleral lens? Design over sclerals, much less binding, conjunctival compression less than sclerals, much less risk of increasing the intraocular pressure, significantly more tear exchange without fenestrations, some movement to refresh the tear layer, which must be helpful long term, pose less risk for corneal grafts. If you're fitting a graft with a scleral lens, be very careful. I've seen some horrific results quite quickly with scleral lenses on corneal grafts, and reduced need for options. So my final slide now, very time to efficient, usually only take 20 minutes to settle before you can judge the final fit. You don't need to wait 4 hours, send your patient out. No reports ever of conjunctival prolapse. Midday fogging, very uncommon. Much less frequently need to be refilled during lens wear. Do not need to be as large as sclerals and are much easier to remove. So why do I prefer corneal sclerals over sclerals? They can be used in the majority of cases where a scleral lens is indicated, give the same advantage of comfort and stability without many of the potential downsides that setting off the cornea can cause. So I think we're going to see some big fallout from scleral lens wear. Sincere thanks to Minicon, who sponsored my trip here to India from New Zealand, a long way to come, and to the AIC and to all of you for staying awake. Thank you very much.